Okay, hello and welcome. Greetings and welcome. I'm Inez Ponce, and I am the director of the Center for Health Policy Research. The center was founded by Dr. E. Richard Brown, finally known as Rick, 25 years ago. During his life, Dr. Brown advocated strongly for a care-for-all system that would ensure that each person receives needed health services, and that the smart design of such a system would be informed by good data and sound empirical evidence. To this end, Rick launched the California Health Interview Survey, a population health survey that has tracked the state's report card on health coverage since 2001. It actually started earlier, but we were using the current population survey, but it just wasn't enough for California. Rick would be very excited to see this genuine discussion that's going to occur today of improving health care in California that's currently taking place in the legislature, the administrative offices, and the governor's office. And he would want to know what researchers, and you saw some of us here, we're very multi-talented. We can actually do a lot of things besides research, could have some AV skills, and academics, and we can move furniture, could do to assist with this very important conversation and that this conversation happens. Honoring that spirit, the symposium's topic is so timely: universal health care in California. I am thrilled to present this program of esteemed speakers, moderators, and discussants to outline possible system designs, policy proposals, and important areas of research. We have a packed agenda today, so each speaker will introduce themselves. But in line with our Golden State's hospitality and openness to new cultures, food, languages, and ideas, I do warmly welcome our three featured speakers. Zhongmei Cheng is a health policy research analyst at the Woodrow Wilson School of Public and International Affairs at Princeton University. She'll speak about her firsthand experience in the choice Taiwan made to pursue a single-payer system. Reza Dieber is from the University of Toronto and will speak about Canada's long-standing single-payer experience. And Joseph Kutzen, who perhaps traveled the longest to join us, Joe is the coordinator and lead of the healthcare financing team at the World Health Organization in Geneva. Joe will share several examples of healthcare financing models around the world. I have immense respect for Rick's widow, Marianne Brown, who supported, jump-started, and inspired this event, a kickoff for the Center's 25th anniversary celebration. I thank two departments that Dr. Brown was affiliated with at the UCLA Fielding School of Public Health, my home department, the Department of Health Policy and Management, our chair is here, Jack Needleman, and also the home department of our associate center director, Steve Wallace, and it was Rick's home for a while, the Community Health Sciences Department at UCLA. As you'll note in the program, and I hope you all got the program, it's outside, it looks like this. The University of California's institutional commitment is very telling here. With academics that will present today, my dear colleagues, coming from campuses up and down the state, topped with the generous support of the California Program on Access to Care and the California Health Benefits Review Program, and Garen is here, who's the director. I thank all of the participants of the E.R. Brown Symposium, and a call out to the staff at the UCLA Center for Health Policy Research that made this happen. I also thank all the technical staff here at the Capitol. Thank you, thank you. So let's now begin with that promise, what promises to be a robust discussion. Thanks. Jerry Kaminsky.
Thank you, Inez. Around this way. I'm Jerry Kaminsky. I'm former director of the center and have been part of the center since the beginning. Was one of the original 8 people who formed the Center for Health Policy Research back in 1994. It's been a pleasure for me to spend the last 25 years helping to build this center into the strong contributing California and national and international asset that it is today. I'm going to keep my remarks brief in light of the timing, but I would like to say, just like to give you a brief update on current center activities related to health reform in the state of California. For the last 8 years, we have been working with colleagues at the Berkeley Labor Center to develop a micro-simulation model that we call CalSim, the California Simulation of Insurance Markets model. We've been using CalSim for the last 8 years to model both initially prior to the opening of Covered California in October of 2013. We helped model and identify who was likely to take up insurance benefits in the state of California. And on an ongoing basis since then, we have been working with Covered California and the state to continue to identify the remaining uninsured in the state of California. We yesterday delivered a report to, or a set of data books to Covered California on our latest estimates of who the remaining uninsured are in California, both in the absence of the individual mandate as well as what would occur if the individual mandate were reinstituted. In keeping with current legislation that's been introduced in the state and the governor's efforts to expand coverage, over the next few months we'll be modeling the impact of efforts to expand subsidies above 400% of poverty, as well as increased cost sharing or subsidies between 200 and 400% of poverty for people who are eligible for subsidies in the exchange. So we'll be looking at the impacts of those policies. As I mentioned, we've already modeled the impact of reinstituting the mandate, and our estimates are that if the mandate is not reinstituted, that up to 600,000 additional Californians will be uninsured by 2020. We also will be modeling the impact of expanding insurance coverage to undocumented adults as well. So we look forward to continuing to participate and to contribute valuable evidence to the debate about the impacts of expanding health insurance coverage in the state. It's been a pleasure to collaborate with our colleagues at Berkeley on this CalSim project over the last 8 years. One final thing I'll mention that we're working on with the California Physicians Alliance, we are working on developing a calculator for individuals as well as for businesses for them to model the impact of a Medicare for All payment system and what the out-of-pocket or the health expenditures on the part of businesses would be under a Medicare for All plan. So we expect to have that calculator available sometime in the next 2 months, and it's been, again, a pleasure to work in collaboration with CAPA and a very eager team of student volunteers on this calculator project, so you can look for that in the near future as well. So I will, without further ado, turn the podium over to Rick Kroenig. Thank you.
Thank you, Jerry. My name is Rick Kroenig. I'm a professor in the Department of Family Medicine and Public Health at UC San Diego. Ninez has asked me to do two things this morning. First, to express my love and admiration for Rick Brown. And second, report on the results of 5 hearings that were held in late 2017 and early 2018 by the Assembly's Select Committee on Healthcare Delivery Systems and Universal Coverage. And quite generously, Ninez has given me 7.5 minutes to do so I better talk fast. I am honored and delighted to pay homage to my very dear friend, Rick Brown. Rick was a warrior for social justice. He worked passionately to assure that marginalized people in California and the rest of the nation had a better shot at living with dignity and opportunity. And that passion motivated everything that Rick did in his professional life. You've heard already that Rick was an academic entrepreneur par excellence. He came up with the idea of the California Health Interview Survey, and against all odds, convinced a variety of funders to fund this thing. As Rick envisioned, the information that, produced by CHIS has been crucial in advancing a progressive policy agenda on a host of issues in California and the nation. CHIS is really a treasure and would not exist without Rick's vision and energy. As you've also heard, Rick created the Center for Health Policy Research at UCLA, now celebrating its 25th birthday. The center is a trusted and timely source of unbiased information. All of us in the health policy field owe a great debt to Rick. But much more importantly, for me at least, Rick was a loving and lovable person. My love for Rick really grew when we spent lots of time together in the mid-1990s working with then State Senator Jackie Speer and her staff on a universal coverage bill. Now that bill, of course, didn't pass, or perhaps I should say hasn't passed yet, since it doesn't look all that much different from some bills that are around now. But I learned then, as I continue to learn over the next 15 years, that Rick was generous to a fault and compassionate as well as passionate. And Rick was the only warrior who I know who pretty consistently had a twinkle in his eye. I still miss Rick tremendously and often find myself wondering, what would Rick do? I'm pretty confident, as Ninez said earlier, that if Rick were here today, that he would be celebrating the progress that we've made in California in increasing health insurance coverage, would be working on supporting the efforts underway to expand coverage further by building on the framework created by the ACA, and working to move beyond that framework to a more equitable and saner system. Let me move now to my second job this morning, which is summarizing what we learned from 30-plus hours of hearings held by the Select Committee that was chaired by Assembly members Jim Wood and Joaquin Arambula in 2017 and 2018. As you can imagine, we heard a lot in 30-plus hours of testimony, much of it in this room. In my remaining 3.5 minutes, I'll try to summarize the 5 takeaway points that I hope you'll remember. And this is probably a mistake. Usually you're only supposed to have 3 points because people can only remember 3 things. But I'm confident that this audience may be able to get to 5. First, we learned that if the main goal of healthcare financing reform is to get everybody covered, that we can get pretty close to achieving that goal through incremental improvements on the framework created by the ACA. Crucially, expanding Medi-Cal coverage and Covered California subsidized coverage to Californians without documentation, and increasing the affordability of the plans offered in Covered California. Governor Newsom's first budget begins the process of making some of the needed improvements. Last year's Assembly budget made a $1 billion down payment toward this project, and additional resources are clearly needed. Second, we learned that even though we can get pretty close to universal coverage through incremental improvements on the ACA, we would still be left with an incredibly inequitable and inefficient system of paying for health care, and we would still have very little ability to moderate the growth of health care spending. We heard a lot about the inequities and inefficiencies of the system that we've got now. Very high prices, very high administrative costs, lots of low-value care, and we'll hear from the international panel a variety of ways to try to make improvements. We learned that there would be many advantages to a system of unified public financing in which all Californians received coverage by virtue of being Californians, without regard to age, employment status, income, or disability status. And we learned that there would be many advantages to getting rid of the distinctions among Medi-Cal, employer-sponsored insurance, Covered California, and Medicare. Third, we learned that to create a system of unified public financing, the federal government would need to write a check to the state of California for the approximately $75 billion a year that is spent on Medicare, and another check for the approximately $67 billion that's spent on Medi-Cal, and another check for the $6 billion or so in subsidies for Covered California. Even a sympathetic president, which we clearly do not have, would not have the authority to write the Medicare check. Statutory change would be needed. This can't be done through waivers. The Medi-Cal check could potentially be accomplished through waivers, but we learned that even there, legislative change would likely be needed. And clearly, none of this is going to happen with the current administration of Congress. Even a sympathetic administration in Congress after 2020, not so clear. Fourth, we learned that aside from the problem of getting federal government cooperation, the biggest challenge to unified public financing is transforming the approximately $125 billion a year in employer and employee financing from private contributions to publicly raised tax funds. Related to this, we learned that a big obstacle to change is convincing a substantial fraction of the 15 million of us in California with employer-sponsored insurance that will be better off with a unified publicly financed system, and that an equally big or perhaps bigger obstacle is convincing a substantial number of employers to publicly state that they'd rather be out of the middle of the healthcare financing equation and would prefer paying a tax. Fifth and finally, we learned that the question of whether we will continue to use health insurers as intermediaries between the government and healthcare providers, and if so, whether those insurers must all be nonprofit or whether some of them could be for-profit, is an important but distinctly secondary question to this primary question of whether we're going to continue to rely on employer-sponsored coverage. I am sure that I have not done justice to the 30-plus hours of testimony that we heard, but I hope I have brought as much justice to the presentation as my friend Rick Brown would have if he were here today. Especially at a time when the situation in DC looks so bleak, I am excited about the opportunities we have in California to make progress, both on the shorter-term goal of improving on the ACA and on the longer-term restructuring task. I thank all of you for being here and your work on these projects, and I'm really looking forward to the rest of the morning. So thanks very much.
Thank you, Rick. 7.5 minutes. Thank you. Our next speaker is Sung Mei Cheng. Let's take this away so we can see you.
Can you hear me? Yeah, okay. I'm so happy to be here today and very honored to be invited. I have to press this, right? Yes. That's better. Thank you, thank you. Yeah, I was saying that I was really happy to be here, to be a part of this wonderful symposium, Richard Brown Symposium, and to share your enthusiasm and vision for trying to achieve universal health coverage for California. And it's not projecting it. That's your department. I can say the dog ate my homework here.
There we go.
Okay, go back. No. Nope. Okay. Yeah. All right. So, oh yeah, right. Okay. Okay, if you can make that picture larger, please. So my mandate this morning is to talk about three things about Taiwan's single-payer national health insurance program, and hopefully offer some lessons that you will get from this talk for California. So the three things is I'm supposed to talk about how it came about, and most. Okay. And secondly, how does it work? And then thirdly, how has it performed? How has it done? Has it achieve the policy goals that the planners envisioned at the very beginning. So here I have prepared a profile of Taiwan, and the red words in parentheses is California, so you can have a look. California is much bigger population-wise than Taiwan, and also Taiwan is much older than, well, okay, second line, right? You can see Taiwan has an older population than California, and California is much richer than Taiwan in terms of GDP. But look at the per capita health spending. Taiwan spends less than half of what California spends per capita on healthcare. And Taiwan also has a better infant mortality than California because of access to prenatal care, etc. But Californians live a little bit longer than the Taiwanese. But I think that's affected by some other factors. So the genesis, how did it come about? So first I want to tell you about the guiding principle in Taiwan's national health insurance. It's just 2 words. What is the distributive ethic shared by Taiwan society as a whole? 2 words, social solidarity. They think that healthcare everyone should have, and it is a right. In fact, this value is embedded in Taiwan's constitution. The constitution stipulates that, there's an article in there, that the government, to provide social welfare, shall implement social insurance institutions. Now, this one provision gave the constitutional mandate for social welfare programs in Taiwan, of which the national health insurance is one. And the government, therefore, decided in 1986 to build and implement a universal national health insurance program. So now you'll wonder what was there before the national health insurance. So I take 1950 because the government of Taiwan left China. They got defeated by the communists and went to Taiwan in 49. So it really began in the fall, late October 49. So it really began in 1950, the government. Until 1995, that's the year that the national health insurance was implemented. Well, they had 13 social insurance programs, like labor insurance, farmers' health insurance, government employees' insurance, etc. But they only covered 59% of the population, which means that 41% of the population were uninsured at that time, up to 1995. But then, in the 1980s, Taiwan had a window of opportunity. Okay, I'll explain why. The +1, I'll explain that also. So, this window of opportunity is the following. See, in the 1980s, there was a confluence of several factors that made this very bold initiative possible. These factors are, 1, there was a very strong popular demand. People wanted health care. They wanted health care because they wanted it, and I'll say why in a minute. There was also political competition because the government, which had been in power from 1950 up to 1995, was at the single government, the nationalist government of Taiwan under Chiang Kai-shek. And Taiwan had been under martial law up until 1987. But in 1987, Chiang Kai-shek's son, the then president, canceled the martial law. And guess what? Political parties arose. So then, they represented significant competition to the ruling government. So, of course, the ruling government wanted to stay in power, so they were eager to do things for the people. And then there was substantial economic growth. Taiwan, for decades, since the 60s, double-digit economic growth, which provided the financing money, surplus, economic surplus, for the government to implement so ambitious a program. So you cannot do one without the other. And then I would say also leadership, because the leader of Taiwan, President Lee, and his premiers saw this opportunity, wanted to just stay in power, and so he seized this opportunity, right? And another thing he did, which was instrumental, was that originally in 1986, when they decided to establish the system, they say, all right, we will implement that in the year 2000. But this president moved the implementation date up by 5 years. He said, well, let's do it by 1995. People say, well, but we're not ready. But he says, yeah, but we're ready enough. Let's just do it. Okay? And this turns out to be a very, very lucky for Taiwan, a move. Because remember what happened in 1997, the Asian financial crisis struck. And that affected, a lot of the Asian economies were decimated, Korea, Indonesia, name it. Taiwan's economy was affected because of trade and all that, so economic growth slowed. So by the year 2000, if they had waited, the government say, oh, well, things changed. We now are not growing so fast. Maybe we should think again about implementing national health insurance. But by then, they already had the national health insurance. So that was lucky for Taiwan. So now let me just say quickly about what is the +1 factor? That takes us to this question. How did Taiwan decide to go single payer? People always ask, when they have all these options, how did it decide to go single payer? And I would say that this has to do with one man who happened to be the right man at the right time and at the right place. And this man is Uwe Reinhardt. Thank you very much. Uwe was born Germany, but he left Germany to go to Canada when he was draft eligible, because he said, I refuse to salute German generals for what they did in World War II. So he left by himself to Canada. And from there, he went to the United States for graduate studies, and then just stayed and taught at Princeton for his entire academic career. And so I would like to dedicate this talk to Uwe because of the tremendously good thing he did for the people of Taiwan. So Uwe Reinhardt and Taiwan single payer. The idea to go single payer was recommended to the Taiwan government in December of 1989 by Uwe Reinhardt. He was serving as a high-level government advisor at the time. Government was planning already to build the system. Here is what I was waiting for. Yes. So Uwe had no idea, but he said that this was his most significant health policy contribution for his entire career. But when Reinhardt recommended this system to Taiwan's government, so it's a single-payer government, nobody really knew what it was, right? Oh, so what is a single-payer? So he said, well, okay, let me think about it, and came up with another name. He just called it one pipe. Okay, single pipe, one pipe. And he drew a picture for the Taiwanese. And he called it alternative financial arrangements between patients, providers, and third-party payers. And the diagram looks like this. These are two different arrangements, right? The boxes on the upper left side is the insured or taxpayers paying into risk pools. That's where the money go, into these risk pools. No, the financing goes into these. And then the money goes into the risk pools. That's the bottom box. And then how do you pay providers? See, because this money somehow has to be transferred to providers for the services that they provide. Now, here you see multiple pipes going from that risk pool into that upper right box, which is providers, right? So you have multiple pipes from the risk pool going to the providers. That is the United system, multi-payer system. But because there's so many, many are too weak to bargain with the provider of care. You know, a small insurance company is not in a position to bargain with providers, many of whom have grown really, really powerful. But in a single payer system, guess what? You have a single pipe from the risk pool that pays all providers. Okay, and that's where its power lies, because there's a control valve on this single pipe, and that is a secret weapon of a single payer system, because the government who is in charge can fine-tune that control valve. You know, you can let it loose a little bit when things are good, the economy is growing well, but then tighten it when necessary. And Uwe recommended this system for 3 reasons why he thought that way. That would be good for Taiwan. Equity, first of all, that's the first strength of a single-payer system, because under a single-payer system, insurance, health services, all the services are based on need and not on the ability to pay. And second one is that you can control cost very effectively in an egalitarian way. We'll see how and why in a minute. And thirdly, a single-payer system is very cheap to administer, and we'll also talk about that. And it's very easily understood by voters. There's just one form, one claim form. It's all common. They have a common nomenclature, IT system that supports it all. So it's easy to run. But at the same time, right, Uwe Reinhardt made sure that he told the Taiwanese a couple more things. Look to other countries for lessons. So Taiwan held international conferences like this symposium, and they sent their own people out to study lessons. And they rejected systems. They said, whatever you do, do not copy the American health insurance system, because it is so complex that it is almost beyond human comprehension. That's in his book, which is coming out in April this year. And third one is that he says, you know, a single-payer system doesn't mean that it's government takeover, right? So keep your private delivery system, which is predominantly private, keep it, it's okay. You just make sure that the government is in charge of financing and the payment of the system. So, quickly, planning, legislation, and implementation. Planning theoretically took 7.5 years, but in the first few years, not much happened. Everything happened towards the end of the 7.5 years. And legislation took them only 18 months to push the bill through. So they enacted the National Health Insurance Law in 18 months. And then boom. What is 9 months after the law passed, they implemented it. So we call it the big bang of the birth of the National Health Insurance, and overnight everyone became eligible for insurance. So now we look at how it works. Let's first have a quick overview of how the system works. First of all, it's a government-run system through 6 regional offices. Okay, but the nerve center is in Taipei. That NHIA, and National Health Insurance Administration, is like our CMS. There's a mandate, all citizens, and then later on they added all legal foreign residents. And look, they spend 6.1% of GDP in 2017 on healthcare, and we will see in a minute what they all cover. In contrast, the United States in 2017 spent 18.1% by our own estimate but 17.2 by OECD, but OECD doesn't count some of the things that we count as national health spending. So just take 18% we're spending. Our national health spending, the Taiwanese healthcare spending per capita is $3,000. Now, in 2017, for the United States, by OECD study, is $10,209, 10209 per capita health spending in the United States in 2017. Population covered is 99, however many, 0.9999%. In other words, everyone is covered. And the delivery system is predominantly private. You can see 85% of beds of the hospitals and almost 100% of the clinics, that's all in private hands, privately owned and operated. And it's very affordable. You pay 4.69% of your salary and wage, plus 1.9% of your additional, say, if you have rent or interest, dividends, that type. And the government sets prices, okay? And therefore, there are no surprise medical bills, which we are all so familiar and so very haunted by them. And then say, well, then are you limited to who you can go see? No. Patients can go anywhere, see anyone, anytime they want, anywhere in Taiwan. You know, if in the morning you saw somebody in Taipei in the north, and in the afternoon you decide to see somebody in the south, Kaohsiung, you can. Just take a train and you're there in 2 hours. And 93% of the providers, they sign a contract with the government to deliver services. And you say, well, if they're on a premium financing system, they're not on tax financing. And this, I hope that Americans would consider the premium financing route. People paying like they pay for their health insurance every month, right? Taiwanese pay their health insurance premiums every month, except to the government. They don't pay it to a insurance company. They're used to doing that. And what's impressive is look at the collection rate. It's basically 99%. They collect on time, the government. And the benefits are really, truly comprehensive. It's inpatient care, outpatient care, prescription drugs, dental care, Chinese medicine, prenatal care, daycare for the mentally ill, home nursing care, palliative care, dialysis, you name it, they cover it. And there's a small co-payments, and but if you have one of some major, 30 major illnesses, co-payments, co-insurance are waived, so you get first dollar free care. And it's fully portable. It's not tied to employers, so it's an individual-based, not employment-based system. And then running it all, helping them run it all, is a very powerful IT system. I'm sorry we will not have time to go into that, other than very superficially. So now we dig a little bit deeper, take a systems view of the Taiwan's NHI by looking at the 4 fundamental building blocks of any health system. Financing, you know, where the money comes from, risk pooling, paying providers, and delivery system. So first, so where does the NHI get its money, right? So from 3 sources, government, employers, and households. These 3 sources come up with 92% of the total NHI expenditure. And the other 7-point-some% comes from the supplemental insurance scheme. That's that little 1.91%. So here is government pays about 34%, employers about 29%, and households about 37%. That adds up to 100%. And this is a busy slide, but I just want to show you that how Taiwan, they divide the population into 6 groups. So depending on which group you fall into, your premium gets subsidies or not subsidies. All depends on your status according to the group. But the point I want to make is that the government pays 100% for the poor, the premium. So they have needed access to needed care. Now, risk pooling. There are 3 necessary conditions, all of which Taiwan has met. You need them in order to build a universal health coverage system. The first, you need mandate. So I'm very happy to hear Governor Newsom is thinking of reinstating the mandate. So that puts everybody in a risk pool, and that spreads the risk, which keeps a low premium at as low a level as is feasible. And second is guaranteed issue. You don't look at people's pre-existing conditions. You don't look at their age or gender. And third is that you need government subsidies, enough subsidies. That's an important word, adequate government subsidies to the poor and near poor in order to help them, pay their insurance premiums to entitle them to full access to health care. I want to show you, this is Uwe's slide, Uwe Reinhardt's slide. I like that stool. I wish I had a stool like that. He says his observation that health reform of the insurance market reform is a 3-legged stool, so Reinhardt says. And so the first one is guaranteed issue and community rating, right? So you don't look at you don't make sick people pay a higher premium. That's a no-no. You need a mandate on individuals to be insured. And the third is that you need adequate subsidies toward the purchase of health insurance. And he said, you cannot just have 2 of the 3 because guess what? The stool won't stand, right? They go together. You need all 3. So that's Uwe's contribution to this symposium. Okay, paying providers in Taiwan. Providers get their revenues from 3 sources. The biggest one is from the government. They get it from fee-for-service, from DRGs, etc. And they also get paid with these small patient user fees. When you go to a doctor or hospital, you pay a registration fee. You say, I'm here, I'd like to see such and such. And they register you, that kind of registration fee. But there is small co-payments and co-insurance. But then waived if you are poor or if you have one of 30 major illnesses. And they can also sell products and services that's not covered in the, that is a potential source of trouble because of this thing called supplier-induced demand, the SID. So that can become a problem in Taiwan. Now, the fee schedule is uniform, it's national, which is set by the government. And what this means is that all providers who sign up with the government are paid the same fees. So in Taiwan, there is no price discrimination. There's no in and out of network charges. There are no surprise medical bills like we do here. And patients' socioeconomic status has no bearing. There are no Medicaid fees. I know that in Princeton, some providers, some years ago at least, they have a sign on their door saying, we do not see Medicaid patients. But in Taiwan, you go see a doctor, the doctor would have no idea if you're rich or poor because, he gets paid the same. And fees only vary by the level of provider organization. So like a medical center would get a higher fee than a regional or local hospital. That's reasonable. And no balance billing is allowed. So the delivery system, right, they have very, very easy access, people. See, this is a point to, again, emphasize to Americans. They say, well, single-payer systems, they ration healthcare, you have limited access, but not in Taiwan. 85% of patients reach hospitals or clinic in less than 30 minutes, and the waiting time It's very insignificant, if you can call it waiting time, because 83% of patients get to see a doctor waiting less than 30 minutes. And here's some example of the so-called waiting times in Taiwan. For cataract surgery, it's 11 days. Total knee replacement, 17 days. Total hip replacement is 12 days. So that's very, very good access. And very good outcomes, too, I should add. And you say, all right, to tell you, they are very high users of their health system. The average per person visits to doctors per year is 12.1 times, right? Compared to the OECD average of 6.3%. And they stay in the hospital twice as long as the OECD average. And then also they look after their disadvantaged populations. They take health care to people living in the mountains, in offshore islands, with this integrated delivery system. They have these buses equipped with MRIs, CTs, X-ray machines. They can do all kinds of things for those remote area residents. Okay, now we look at the performance. How has it done? Well, here's a health spending map here. I think we all know who the exceptional spender is, right? See, I said this is OECD, but our own CMS estimate is 18.1%. And here's Taiwan, 6.1%. And here's our fellow single-payer system. Taiwan drew much inspiration from the Canadian system when they built theirs. And this graph, I think, is interesting because it shows you the growth in national health spending in the US and some other OECD countries and in Taiwan. You will see Taiwan has the lowest level of spending, and the growth has been very even. Can you all see this map? And yeah, soon, right. So I want to point out that you can see Taiwan is a single-payer system, so are Canada and Denmark, but somehow their spending level is much higher. But then look at these three, Germany, Switzerland, and Japan. These are all payer systems. Their spending is not a whole lot more than the Canada and Denmark. So all-payer system is something that may be easier to get to for America, in America, than an immediate single-payer system overnight. So how did it contain cost? Well, it was government policy. It was a goal to contain costs because health spending was going through the roof, growth. So they used global budgets to cap annual spending, and government set fees, and then again the powerful IT system that tells them real time what their spending is, really on a 24-hour basis. They know that. So they phased in the 5 sectors of the overall global budget system, right, by and by. But the one I want to call your attention to is a hospital global budget system. That's a big one. It took up 63% of the total health spending in Taiwan. So to control that sector means you will get cost control for the whole system. They introduced that in 2002, and you can see what happens. Look at the green arrow pointing down, how the growth just dropped, like precipitously, as soon as the introduction of the hospital global budget in Taiwan. And since then, Taiwan's growth for the whole system has been about 3.94% a year. And it stayed that way. That's why you see this very level spending in that earlier chart for Taiwan. And here, I'm sure you cannot see the numbers. I dig out, this took me quite a bit of work to put together. Prices, right? It's the prices. Because, I mean, Uwe says it's the prices. Stupid, but the prices. So there was a follow-up article in January in Health Affairs. It's still the prices, stupid. And so I said, okay, I'm going to respond to that. So I dug out some Taiwan prices. Take the drug Harvoni, that is a drug for hepatitis C. a full course of treatment, these are the same dosage, same prescription. Okay, lovely. It's $2,132, okay? And over here is the US. Look at the average price for Harvoni is $32,114. And then our 25th percentile is a little bit lower, 31% at $31,640. But our more expensive 95th percentile, the cost for the same amount of Harvoni is $33,135. Compare that to Taiwan's $2,132. By the way, in today's Washington Post, there's an article on Taiwan. You'll see those prices. And here, I just want to give you a, take C-section. In Taiwan, a C-section costs $1,400. In the United States, the average price is $16,100. And it can be as high as $28,500. And the lowest is $11,400. So you can see that the price difference is in terms of multiples. So, yeah, I'm coming to the end now, this IT system. Because I think it's something that every state in this country thinking of doing a single-payer system really ought to pay attention to this. The planners had the vision. They wanted to hit the ground running, and it helped them so much. Administration is efficient and very low cost. This is what they're spending. Less than 1%, 0.77% of the total health spending in Taiwan goes to administration. And they have a staff of 2,800 within the National Health Administration that runs that whole system for the 23.4 million Taiwanese. And you'll wonder, are people happy with it? Yes, they're very, very happy with it. Look at that last number here. 86.5% of people are satisfied. This is as of December 2018. And that is all. Thank you so much.
Thank you, May. If you'd like to see more of May, we're actually having an event tomorrow at UCLA. Our next speaker is Reza Deber. And Reza is from the University of Toronto, as I said, and she will talk about Canada.
So can we get this up?
There we go. A lot of us academics were in the AV club in high school, so okay.
Yeah.
There we go.
Hi. Thank you so much for inviting me. I've been asked to talk about Canada, and people ask, what's the Canadian system? And it's a trick question, because there's no such thing as the Canadian system. Because Canada was founded shortly after the U.S. Civil War. And so one of the things that was obsessing people was how to make sure we did not have that. And so making sure there was a clear distinction between what was a federal responsibility and what was a responsibility of the provinces, which is what we call states. And so what they did is they said everything that would be expensive and national interest was federal, everything else was provincial. And in 1867, health care was not exactly what you considered to be a big deal. A hospital was where you went if you were too poor to have a nice home to die in. So they said that health care is a provincial responsibility. And it means there's a lot of variability between provinces, within provinces. One size doesn't fit all. So you can't say this is what Canada does, but there's a lot of commonalities. It's important to recognize that Canada does not have socialized medicine. If I was given a lecture to my students, I'd make the distinction between what financing is and what delivery is, and the whole public versus private, and the different flavors of public and private. And in Canada, we have a single payer system for public financing some categories of health services, not all of them. As you'll see, there's a whole lot of ways Canada looks very much like the United States. And the services are delivered by private providers, often not for profit, or what Bob Evans calls not only for profit, which is physicians who are not just trying to sell you stuff to make a buck out of you. But it's important to recognize we have almost no publicly delivered care in Canada. It's almost entirely privately delivered care, although depending on what province you are, the government may be trying to give more and more control over it and making it almost quasi-public in terms of that. And to make things even more confusing, we call our system of publicly financed hospital and medical insurance Medicare. And it is very similar to U.S. Medicare, except that there are no copays and no deductibles to insured persons for insured services. And also what differs from some is that the money usually comes out of the tax system, not out of premiums. So it just goes into government revenues, and the government then decides what they're going to be doing. And I was asked to say why we went in that direction, and there was two main reasons. One was the recognition that people weren't as healthy as they could be. And some of the histories talk about things like the 1918 flu pandemic and the recognition we should do something about public health. But the other was that, like World War II, a lot of people who were trying to enlist in the Canadian military were turned away because they were not healthy enough to be killed for their country. So the recognition was maybe we should be doing something to make sure, and also question what do you do for veterans, and shouldn't they be getting care? But the second reason came from providers, because providers were finding that if they were ethical enough not to turn people away and give necessary care, they were ending up with a lot of bad debts. And there's all these stories about doctors being paid in chickens, or if at all, and hospitals having bad debts, and rural areas not being able to keep providers because they couldn't make enough money to have a go of it, and patients having financial hardships. So the two pushes for it came from those. And there was a lot of failed attempts to put in national programs, and they were all fighting about federal provincial stuff. So the first step was the federal government gave some targeted money, they call the National Health Grants Programs, to do particular things. Okay, we'll give you some money to do public health for TB. We'll give you some money to train health personnel. We'll give you some money to build hospitals. The next thing that happened then is the provinces took action. And Saskatchewan did take the lead in 1947 and introduced a publicly funded insurance for hospital care. It was Tommy Douglas, who's also well known in the U.S. because his grandson is Kiefer Sutherland. But so Alberta and BC followed in 1950, and eventually the federal government in 1957 passed something called the Hospital Insurance and Diagnostic Services Act, and it said, look, we the feds will give you money, approximately 50% on the dollar, but of course, being a government thing, was not that simple. There was all these little nuances about how they decided what they were going to split and how they took per capita, provincial revenues into account. But if the province chose to participate, they could set up a system of single-payer insurance for hospital care. And for some strange reason, the provinces where people were paying taxes to give care for people in other provinces said to their provincial governments, why on earth aren't we doing it? So every single province by 1961 had a provincial system of single-payer hospital insurance. Then they set up the whole commission, and it was set up by conservative government. This is not a left-wing thing. This was John Diefenbaker. And what they found was that there was 10.7 million Canadians with some form of medical care insurance, but there was another 7.5 million that didn't, and only less than half of doctors' bills were being paid through insurance. So what they did is Saskatchewan took the money it was saving by getting federal money, and it set up a publicly funded coverage system for physician services. And it led to a physician strike, and the deal that they struck at the end of the strike was, okay, doctors are going to be private providers. This is not an NHS model. They're private providers, but they have a single payer paying the bills. And again, the feds followed. And 1966 passed the Medical Care Act, which said that there would be federal cost sharing for single-payer provincial insurance plans. And by 1971, every single province had set up one. So the birth of Canadian Medicare nationally is 1971, okay? And the common features is that there is full coverage for all medically necessary care, but only if it's delivered in hospitals or by physicians. You can go beyond it, but you don't have to go beyond it. So that there is a lot of variability in private insurance and US-style things for all of the things that do not count as physician coverage or hospital coverage. All Canadian residents are covered. It's not citizenship, it's based on residency in the province. So one of the things that you get into as an interesting problem is what happens to snowbirds when you go down to Florida or California for the winter, and at a certain point you're deemed to have lost your residency, and then there's some issues about what do you do about coverage when you're coming back again. But there's no co-pays at all for insured services to insured persons. You can totally pick your providers. There's nothing with that. There's also an ability to set up a thing where specialized services, you go through primary care referrals, so there's not a lot of people directly going to the specialists. So the cost share models have evolved over time. They used to have it that it was only cost sharing for the doctor services and physician services. And then they realized that this was a problem because they tried to set up a nurse practitioner program. It didn't work because you get no money from the feds unless your patient was seen by a doctor. So they then changed the model and went into block funding. So they took a bunch of cost-shared programs, the doctor's program, the hospital program, social services, post-secondary education, and put it into a combination of tax points and block grants. And they go right into provincial budgets. And the only thing that has terms and conditions on it is the doctor-hospital piece. It's called the Canada Health Act, passed in '84. And if you don't comply with the Canada Health Act terms and conditions, the feds can withhold funds. Okay? And these programs are incredibly popular. All legal residents have coverage. Hospitals and doctors don't have as many bad debts. Admin costs went way down. And it's so popular that it basically has not changed since its introduction. The only big push that you have is to extend it to the services that aren't covered. And even when governments try to undercut it, they have a rhetoric which implies that they're trying to make it better. So they will not say, I mean, Ontario right now has just introduced a new piece of legislation that might indeed foul up things quite badly, but it's all being sold as we're taking the Canada Health Act provisions and extending it to more services. Okay? There's variability across the provinces. The services delivered outside hospitals by non-physicians don't have to be covered, but they can be. So you'll have differences in dental care, which tends not to be covered much anywhere, rehab, outpatient pharmaceuticals, mental health, long-term care, home care. And what you have is a lot of people do have private insurance, often employer-based, for those services. So that model does resemble the U.S. model. It's not universal. You can have co-pays, deductibles. You can have all the rest of it. It's very important to recognize when people talk about Canada, what we call public hospitals confuses the heck out of people because they're not public. They're charitable, not-for-profit organizations. A lot were founded by religious groups, particularly Catholic. They happen to get a lot of their money from the public sector sources, but they manage their own affairs. Although depending on where you are, the, quote, accountability mechanisms may shift them closer to this quasi-public model. So in some provinces, they don't have their own hospital boards anymore. Ontario, they still do. We'll see what happens with it. And people who work for them are not civil servants, so they are not part of government. I want to spend a little bit about why single payer is a really helpful thing to do. And as May noted, a lot of what I'm saying is there's savings on admin expenses. There's better coverage. But one of the key things is this issue about risk selection. And I'm going to do a very brief thing about risk selection because health costs are large and they can be unpredictable. That's why you need insurance. And there was a U.S. medical expenditure study that showed way back that bottom 50% was using 3% of resources, which means, of course, if you do the math, the top 50% are using 97%. And if you're a smart insurer, who would you rather cover? So we did some work with Manitoba data, And we took the population, and they had data for all hospital, all doctor, and all pharmaceutical, whether public or private. And you arrange it from low to high, and I learned a new term, which is a vintile, which is 5 percentile. And we're showing in this the top 1% separately, which is double counting because they're also in the top 5%. Now, if the spending is equal, it should be a flat thing, you know, and we did this, Ken Lamb did it on his thesis, and there is one paper that I have not been able to get Ken to publish other than this paper, but the mean, as you see, was, this is 2005-6, the mean was 2,200, but you can see that 80% of people are below the mean, and you can see that top 1% is really accounting for a large chunk of the funds. And if you look at it by sector, that top 1% was 35%, and it varies by the sector because one of the things is when you look at the Canadian data, everything in the hospital is included in the hospital sector. So all pharma delivered in the hospital, physician care is in there on the hospital line, not the pharma line. So this will represent the outpatient thing. But you'll see the top 1% is accounting for 35%. So if you've got a competitive model, there's not a lot of people you have to not have in your pool in order to make a lot of money. And if you can game the system to not cover those people, you are going to make a mint. And 85% or below. And the running joke is, okay, what happens if you break it down by age and sex? They say old epidemiologists never die; they just get broken down by age and sex. Okay, so there's a lot of variability, and this is the distribution initially by age sex groupings, and you can see here's, oh, look at those over 75, and also look at those really expensive babies because they actually got born in hospitals, so that they're a couple of things there, and you'll notice that women in childbearing ages, because some of them will actually have a child, oh heavens, okay? But we did the same thing, and we found the same pattern in every single age sex group, which is, yeah, the mean for women over 75 is over 9,000, but that's because a lot of it, what you're doing is picking up end-of-life care, and a lot of this is cost shifting. So if you do the math, no, you can't just say, let's take the mean. If I move from being 74 to 75, my spending is suddenly going to jump up by that, because most of that is not what's happening, okay? So given how skewed costs are, and the fact that 80 to 90% of individuals are costs for physician and hospital care below the mean for that group, it's a real problem if you try to have market competition, because the amount of work that you have to do to keep people from gaming it is strong. And I mean, my sister works in the US, and her husband's in the tech industry, and they're in the New York area. And one of their good friends works for a small tech startup. And they had a child with a genetic disease. So they found a reason to fire him from the company, so that they found other reasons, but the reason was they did not want to have to pick up the child's health expenses off their health insurance. So I have known of a few too many cases of people, and young people who get diseases and find themselves either unemployable or fired because in a competitive insurance market, you don't want to have to pay for their care. So, another of the arguments against market competition, and we've got a lot of top-rate economists here, is the distinction between when you're talking about things that are need-based and when you are talking about things that are demand-based. And yes, supply, demand, moral hazard, and all that can apply a lot when you're talking about things that are demand-based. But there's a lot of things that we say if you need it, you should get it. Like if I collapse here and I've ruptured my appendix, I would assume that most people would think I should be treated even though I may not necessarily have the money. And those of you who are, treating patients will have a lot of people who come in where that's the case. Similarly, if I offer you a free, all expense paid open heart surgery at the hospital of your choice, I would assume most of you would not say yes unless you needed it. So what we found for necessary care, and this is not everything, we found that single payers make a lot of sense. First, we save a mint on admin costs. The difference between what it costs a Canadian hospital to do the administration and a US hospital you don't have to go through all of the paperwork to figure out what's being covered. And you don't have the risk selection issues. But the politically tough thing is if you're a payer, you're in a monopsony situation and you can drive much tougher deals with the providers, and the providers don't like it. So there's a little bit of a political minefield in how much you exert that power. The two-tier, and there's a whole big bunch of fights about whether or not we should allow people to buy private insurance for things that are already insured. And what we found, and this is internationally also, is that if you have a publicly funded tier, why would there be a market for privately funded care unless what you could get publicly funded is either inferior or you think it's inferior? So that every place that's tried it has found that this does not control costs or anything else. Okay, so what it tells us is I think we've got to distinguish between things that you're entitled to if you need them, regardless of ability to pay, and things where it's okay to work with the market. And if you have the first category, a single payer public financing makes way more sense. And for other things, yeah, there's room for a market, recognizing that the people who can't afford it may not get it. I mentioned the Canada Health Act. It has terms and conditions. It requires coverage based on where the care is delivered, which is in hospital or by whom. You can go beyond it. You don't have to go beyond it. But as technology is allowing you to do more and more things in the community, what's happening is care will move out of the hospital and move beyond Medicare, and you don't have to pay for them, even though they can be medically necessary. And what then happens is there's a big pressure. There's a whole thing like Ontario and a number of other provinces yelling about hallway medicine, because we way reduced down the number of hospital beds. And then what we're finding is that there's an overflow of patients, what they call hallway medicine, in part because, yeah, although they could be discharged, they'd have to pay for care that they don't want to pay for or aren't able to pay for. So they're staying in the hospital at higher costs in order that they can still get their meds, get their wound care, other things like that. So how do you work it so that you can send the people home without working into a system that you're paying for all kinds of care that you would not otherwise have had to do it? So the home care thing has had a whole big issue of figuring out where are you talking acute care substitution, where are you talking long-term care substitution, where are you talking prevention maintenance, and what is it we should be covering? And that is a debate we have not yet solved. And there's also a lot of pressure on governments to decide, do they want to extend coverage to these non-physician services delivered in the community, including pharmacare, home care, mental health, rehab, and exactly what is it you want to do about that. I'll give a brief observation on the levels of spending. And you'll see that in Canada, only about 70%, just under 70% of healthcare is publicly paid for. So when we're saying single payer, it's mainly the hospitals, 90%, and the percent that isn't there are things like capital costs. Like if you want to buy, you bring a hospital foundation in and they'll do some of that stuff. The physicians is about 99%, but as you go into some of the other things, they may or may not be paid for publicly. In terms of where Ontario is spending, our hospital share is a lot lower. It's been going down as we did it. So about 36% of Ontario's public spending in 2018 was for hospitals, about 25% for physicians, and then bits and pieces for other things. Our share of public spending is on the low side. I mean, we rank considerably lower. We were 14th of 22 OECD countries in 75, but 2017 we were 24th of 36, and our spending's not that high in international terms. I'm going to ask May for a copy of the graph that she had, because I have not been able to figure out the current incarnation of PowerPoint and update this with the new data. It does all kinds of horrible things, including leaving out half the names of the countries, and so I stuck with the 2013, even though, yes, I do have the more recent data. But you'll see that the United States is there to make everybody else feel good. So you say, look at all the problems in our system, and you say, yeah, but at least we're not the United States. Okay, so US was at 16.4%. They'd gone up to 17.2% in the 2017. Canada was at 10.2. We've gone up to 10.4. The OECD average is still about 8.9%. Now, these are the same countries in the same order. And what this is showing is it's a little misleading to look at percent of GDP because fractions have numerators and denominators. So something like Norway, who's spending a lot because they had an oil boom, that spending was still a lower percentage of their GDP. But you can again see that the United States is very high, and in fact, the United States is probably spending more publicly than Canada is, while still, before the Affordable Care Act, having more people without insurance than the entire population of Canada and worse health outcomes. So, you know, yes, some of the moves being made are wonderful in terms of going away from that, but to have a system where you're spending more than we are publicly with fewer, you know, with a whole lot of people uninsured and worse results does not seem like a particularly cost-effective way to do it. I put this thing in because this also shows from the 2015, but the US is in green, Canada is in red, and then I have the UK and the mean OECD. But you'll see the US and Canada looked identical in terms of percentage of GDP until 71, where Canada brought in universal coverage for doctor and hospital care. And you'll see that our growth rate went way down. So this is a sort of an illustration of how some of the cost control stuff comes in, because when we put in the universal coverage, all of a sudden the pattern that looked almost identical started looking pretty different. And the perceived crisis in Canada, I know everyone's always talking about how broken it is, right? Is one thing is that we did a lot of attempts to curb public spending. It didn't keep up with population growth or inflation, let alone aging, new technology, and wage pressure. So there was a lot of push to what do we do about that? Public spending is concentrated in certain sectors, and actually the sectors where the private sector spending is, we're doing a lot faster, growing much faster, particularly things like pharma. And so the employers were finding themselves under a lot of pressure because the drug costs were getting crazy. People keep talking about a crisis, and there's accessibility issues around making sure you get timely access to quality services, all the wait list issues. And you have to be careful on that because a lot of it depends on when you start counting. I mean, was my husband needed, first saw the doctor, they said, oh, you're going to need it, but 3.5 years later, he needed it and got it. By the way we compute wait lists, he was on the wait list for 3.5 years because they started when he first saw the doctor. So you have to be a bit careful when you look at the wait list stats to see how they're counting and what they're doing. There's a lot of issues around financial barriers to care that escapes from the comprehensiveness definition. You know, home care, pharma. There's issues around transportation, because if you start consolidating services, then people in rural, remote communities have to start traveling for the services. And what do you do about that? Who picks up the travel costs? What about the non-financial barriers to getting needed care? Like, what are you going to do with child care if you try to, what's reasonable compensation for healthcare workers? What should you be paying them? So what do I think is broken? I think public financing, single payer, and not-for-profit delivery work quite well. And I think those are really good. One of the biggest problems is how you pay, the allocation thing, because there's not a one best model. You're trading off often efficiency and responsiveness. There can be perverse incentives. Do you want to incent people to provide less care, which you do with global budgets or capitation? Do you want to incent them to provide more care, which you do with fee for service? How much is this going to be susceptible to incentives? There's not a lot of mechanisms built in to ensure the care given is appropriate. Although most providers do a good job because they're professionals, even if it doesn't maximize their own income, but you don't really want to get into a situation where the least ethical people make the most money. And there's also the policy alignment issues between what the incentives are for the doctors and hospitals, which can be an issue. There's also an ethical question about who should pay for what, back to the solidarity. What's the responsibility of society? What about voluntary organizations, including faith-based groups who do a lot? What about individuals and their families? And this is not an evidence question. This is a values question about what is it that we think makes sense. And my policy assumption, and I'm quoting the late political scientist Aaron Wildofsky, who says when you have, well, I think it was California, he says when you have complex policy issues, you don't usually solve them. What you do is you replace one set of problems with a new set of problems. And if you're successful, you like the new problems better than the old problems. And if anybody is interested in more about Canada, there's a book I have, U of T Press, and also Greg Marshallton's thing from the European Observatory, which is available free from the European Observatory site. And thank you.
Thank you. Thank you, Reza. As you know, we are running a little late. I hope you all can stay because there's quite a program that is going to continue. And we'll have...
See if we can.
So now
Can we make it? Let's see. If not, okay.
we can move it.
That's all right. That's okay. Let me try it from here. You can hear me? I think, right? So, thanks. And then if this works, all right, I'll reach over. Yeah. Okay.
Go for it.
As a laser, even better. Okay, good. We've got it worked out. Well, thanks a lot. It's really an honor and a pleasure to be here. I guess what I was going to say is you've heard 2 examples so far, and now I have to give you the other 190, which, yeah, no, I will try to summarize them in the interest of time. In fact, a lot of what we've heard is going to be reinforced, so I like to start at the end. And the messages at the end, first is that what you're trying to do here is what countries around the world are trying to do, either to sustain what they already have in terms of universal coverage or to move towards it. And so there is this, and perhaps one of the key differences, let's say, is that there is something of a, what might be called a value consensus, that this is something that countries want, that they should do. I think that may still be an open question here, but at least it seems in California there is that consensus. In terms of some of the specific messages of what seems to work in terms of health financing, and very similar to what we just heard, these types of principles, and countries look very different in terms of how they operationalize these, but at the core, there's systems that have either automatic coverage for their entire populations or mandatory affiliation. There's a predominant reliance on either public funding, tax funding, or mandatory contributions, which are like public finance, at least I think according to Justice Roberts, right? They have reduced fragmentation in the way they organize the insurance market. And then very importantly, and we heard this, I think, earlier, that it's not just about getting everyone affiliated. You really need to use the money well, and this idea of moving towards a much more data-driven and a dynamic system, unified payment systems to really ensure that you can sustain progress over time. And again, that's what we heard about earlier. And the last message is I always say that optimism is a job requirement and not a personality trait, but it is the case that I think it can happen here, and there are examples in this country of things that have gone in this direction. So what I want to do in a very short period of time is give you the history of what I call public policy on health coverage, and it started really in Europe and in Germany in the late 19th century, and this was at a time when under Chancellor Bismarck, and oftentimes you hear about Bismarckian systems, it wasn't really about health, right? It was about concerns around economic development, military development as well, and the idea that you were looking to industrialize societies. And there was also unrest among the unions and so forth. So really the focus of this and what became called social health insurance, which was effectively payroll tax funded insurance for basically formal sector workers or industrial workers. That was the aim, and this spread to other European countries and Japan. But it's important to keep in mind that the aim was not universal coverage. We heard earlier, there wasn't a whole lot that healthcare could do for you at that time, right? So it was much more about giving this benefit. Oftentimes it was income replacement. It was in the UK in the early 20th century, for example, but not universal health coverage as we know it today. And this is the term we use at WHO is UHC to refer to universal health coverage, but similar to what you're referring to here. So this was really born in a sense after World War II and also after medical technology developed further. We heard earlier the reference to social solidarity. The term that's used in the European Union is social cohesion. In Japan, they talk about human security. But the idea was that their universal health systems were really an expression of those core values, right? WHO was established in 1948, and it's effectively built into our Constitution there as well, in terms of that there should be the highest attainable standard for all people. Universal Declaration of Human Rights. And in many countries' constitutions, notably not the United States of America, but the United States of Mexico, for example, has that in their constitution, that there's a right to health protection. And they've really tried to operationalize that through their reforms. And really, I would say now, and maybe just because I work on it, it's almost considered the global health priority. There will be a session at the UN General Assembly in September on universal health coverage, right? So this is coming, and it's really on the agenda of all countries at all levels of income. Now, the policy implications, and really what I would focus on here is that when you move from the idea of health coverage being an employee benefit to health coverage being a right, then this has some implications in terms of how we think about revenue sources and also what the basis for entitlement is, right? And so we heard some of those examples, and I'll come to some and others in a moment. But this is really the crux of it, that when we go from this idea that this is something that everyone in our society should have, then it implies funding it differently, and it implies also delinking it from things like employment, which really don't need to matter, at least conceptually, for this. At the same time, it's not unlimited, can never be, and no country provides everything for everyone, right? So it requires some choices. Elsewhere in the world, there's a recognition that actually the political leadership, government as is reflecting the will of the population, needs to make that decision rather than it being made purely on the basis of market interactions and insurance companies and so on. Now, this is also something of thinking about it really from the client perspective, and again, this idea of if I'm benefiting from universal coverage, then my job is irrelevant to that. The type of coverage, whether or not I have coverage, shouldn't depend on that. And fundamentally, and this is really where I think sometimes in Europe, where one of the disconnects in terms of talking to Americans like me over when I'm there is I mean, I live there now, but basically is the idea that people worry about things here in relation to their health coverage that are non-issues for them. They have other issues. Every country has problems with their health system. They have other concerns, but the idea that if something happens to them or a family member that they wouldn't have access is not a consideration. It doesn't affect decisions about, do I start a new business? Do I change jobs? None of those things get in the way. So that was my very short history, and now I'm going to give my expat presentation, which is really to say, how does it look, kind of reflecting a little bit back on the U.S. from being overseas for now just about 25 years, which was not by design, it just kind of happened. I think there's some similarities. In fact, one thing we see across countries, we do see some things that systems have in common. Again, even on the surface, they might look different. But then there are very specific things, in particular in the U.S., that aren't found anywhere else, and at least are not considered to be either morally or politically acceptable. And I think this is what we're wrestling with here. And the challenge that you have, and why this is fundamentally, we're going to talk mostly about instruments and mechanisms, but this is fundamentally a political issue, right? Deciding whether or not to do this. So I'm just going to turn now to some of the things that countries have in common. And as I said, much of what we heard already is reflected here, that for sure there's a recognition that if you're providing universal coverage, then it has to be based predominantly on public funds, or again, mandatory contributions are typically a combination. And in fact, general budget revenues in particular play an important role in every system that has universal coverage, in some countries, it's the main role, like say in the UK or in Sweden or Spain and so on. But in others, it's still that have a mix of payroll tax or mandatory contributions. There's also an important level of tax funding that goes in there for some of the reasons that May was talking about. There's low-income populations, poor, vulnerable, that you need those general revenues to ensure coverage for non-contributors. The other thing we're seeing in a number of countries, actually, we just put out a paper, came out yesterday, looking at how Hungary has shifted the revenue sources for its single national health insurance fund. And in a way, if you just look at the data on what agencies are making the expenditure, you would see that basically their health insurance fund is responsible for about 90% of public funding, and then there's some direct supply side funding coming out of the budget. But if you unpack the revenue sources, you would see that it was the case that, before, most of that health insurance fund's money were coming from payroll tax, about 80 to 90% of it in the mid-90s. Now it's about 60-40, 60% general revenues and only 40% of the employer contributions. So they've shifted those sources, and precisely because of this bottom point, which is really to say we're concerned about lots of things. One of them is economic competitiveness, employment, and so forth. We need to maintain coverage but reduce pressure on the labor market, and the way to do that is to delink from employment. This is what France did also some time back, where they used to have predominantly a payroll tax-based system and so on. They keep the employer payroll tax, but they delink coverage from that now. But for everyone else, for individuals, they've broadened the base to taxes on all income, right? So they still use some combination of earmarked and general revenues and so on. And again, critically, and we'll come to this, a single uniform set of benefits. Now, that was mostly on where the money comes from and how entitlement is defined. This point is again, both Reza and May made these points, that it's not only about more money, right? And one of my slogans is, you can't just spend your way to universal coverage, okay? And obviously, if any country could, it would be here, right? So that's, that's clearly part of the challenge. I think this point is just, sometimes we all work in this field, but it's just reminding ourselves, and Reza gave this example, you're not going to get an open heart surgery because it's on sale, okay? So this fundamental points about why health markets are different than regular markets. It could be that regular markets have other types of concerns, but, we intervene a lot to support agriculture, which kind of works reasonably well as a market, and we don't intervene that much to support health. And we being, I live not far from the European Union. They spend, I think, 40% of European Union expenditures are on just farm subsidies, for example, right? So, this is a hugely distorting thing. It's not a technical decision, of course, but it's just something that in this country we spend a lot on that, and we don't intervene where markets are actually failing, in a sense. So discussions, you hear a lot about supplier-induced demand here and conflict of interest, but it's not limited to the United States. These are things that we see everywhere. This is data from Thailand, which is actually, Thailand has really one of the stars internationally of universal coverage. And part of it, the reason is that they actually identify their problems and try to do something about it. But this is just an illustration that the Thais use. This is basically the cesarean section rate. And the Thais have 3 different health insurance programs that cover basically the whole population. They had in red, which was a traditional kind of social security scheme for the formal sector, private formal sector workers. In green here was a special scheme for civil servants, right? And in red is what they call this fully tax-funded system called the Universal Coverage Scheme, which covers everyone else. Now, when they put in this Universal Coverage Scheme, the idea was to merge them all into one. But the beneficiaries of the other 2 programs, and especially the civil servants, resisted that. And so they still have these 3. These 2 schemes are paying basically within a budget, on a capitation system or DRGs within a budget cap. not a surprise, the civil servants are basically paying on a fee-for-service basis, and there's big margins for doing cesareans. So it's, they've probably done the analysis to show there's nothing about being a civil servant that actually raises the risk of needing cesareans by twice the rate of the rest of the population. So it's probably something to do with the payment incentives. And China, I don't know how many people are familiar with the Chinese health system, but when they basically liberalized their economy in the late 70s, they treated the health sector like any other sector. They didn't take it any differently. They pulled out a lot of the subsidies. They basically told the hospitals, you're on your own. And the system has become what I call a public for-profit system. Theoretically, most of the providers are government-owned. They are government-owned, but it's all about making money. And one of the ways they make money, and my colleague Winnie Yip from Harvard has this nice picture of the hospital advertising its CT scanner, is they basically get all of the staff in the hospital become investors in this high-tech equipment because the high-tech services were outside of pre-existing price controls. So there's, they can charge kind of what they want. And there are, everybody actually now has insurance, but it has high percentage co-insurance rates on it. But basically everyone becomes an investor, and then everyone has a common interest to maximize the use of these diagnostics. And they've had a lot of other really health damaging consequences of effectively turning the system over to the market. Oops, sorry. So now in a more positive example, and this is a bit of a complicated slide, so I'll walk through it, but it's just to illustrate that actually if you get the policies right, you can make a difference. So on this y-axis is, and this is basically based, my colleagues in the European regional office and where I used to work in Barcelona have done a series of studies on financial protection in different European countries and then link those to different policy measures. So this is really the incidence of catastrophic expenditure. I won't go into the methodology, but basically large financial burden on households from out-of-pocket spending, right? So, and then this is different countries. And what we see is over here in red are countries with very high incidence of catastrophic spending. And what they have in their kind of cost-sharing, co-payment design are reliance on percentage cost sharing, right? So in a sense, what it's saying is the sicker you are, the more you need, the more you're going to end up paying, which is really not aligned with the policy objective. And over here, the better performers have a mixture of policies. So in these three countries, which are Slovenia, France, and to a lesser extent Croatia, they actually have a uniform benefit for the whole population with large copays, but then everybody gets complementary voluntary insurance, effectively like Medigap coverage. And they had, in France, for example, some big inequalities in the availability of that, so government stepped in and subsidized the poor for the voluntary health insurance. So it's still overwhelmingly publicly financed. So that's covering here. A lot of the other countries had co-payments, but they were not defined in percentage terms, but in fixed levels, so that you actually, and one of you said earlier, you actually knew ahead of time what it is you'd have to pay, which is like a really radical idea for something that's supposed to be about markets, right? That you would know the price and could actually make a decision. A number of the countries are able to implement exemptions for the poor, or else if you have good information systems, you have the co-payments, even with percentages, but you have an annual cap that can be determined in either a fixed amount or in relation to your income. It really depends on your IT. So this is just examples of how different countries, and I can give you all the abbreviations, but they're basically all in Western Europe, that they use different measures, but the core issue is that you've got even where you're using co-payments, that they're fixed, they're low, they're predictable, and people know them, and that there are protections for those in lower income, and getting away from what a lot of countries have is almost default mentality that you say, well, we just use a percentage, and not thinking, okay, well, what will that do in terms of the policy objectives we're trying to serve? Because it really means, and as I said, that the more you need, the more you have to pay, which is just the opposite of what we're trying to do. So when I started to summarize, and this is not, I left out the other 175, I guess, or so, of different, what might be called UHC models of financing. again, they look quite different on the surface. So you have, like in the Netherlands, Switzerland, Germany, relying on competing insurers, but a standard package with risk adjustment. Okay. In the Netherlands and Switzerland, there's a mix of for-profit and not-for-profit. In Germany, they're not-for-profit. One thing you'll see in all of these over here is that regardless of the insurance market, you have a unified payment system, whether what we call here an all-payer system or so on. So you get these different things. In Sweden, Denmark, and Spain might be where I'd lived, I know it a bit better, a bit like the Canadian examples where you have a national framework, but each what are called autonomous community, or basically province equivalently, then organizes its own system. So in the Catalan region where I lived, it's fully funded from taxes. There's an agency called CatSalut, which pools that money and then contracts with public and private providers, and everybody's covered. And also about 20% of the population buys supplemental voluntary insurance. But basically, it's a it's residence-based system and so on. So you have these more decentralized things. I think one of the issues that may come up in the discussion is, in a way, there's lots of things that can be called single payer. And I think maybe the definition, or I was writing down some ideas of what to call it, thinking of it as a system where there's a single or unified payment system for the population in a defined geographic area, right? So that geographic area could be a whole country, it could be a state or a province or a county. But if you have multiple single payers with overlapping population coverage, then you actually don't have a single payer, right? So that's really it. But you may have, again, like in the German or Dutch system, you can still have multiple insurers, but effectively functioning a single payment system. Japan has this as well, where they don't compete. You're assigned to different insurance funds. There's like thousands of them. But everything goes into a single payment system, which is an extremely complex fee-for-service relative price system and ultimately operates within a budget. So there's lots of different things. And even at the bottom here, and I'll come to that in a moment, even in this place far away on the east coast of the United States called Maryland, where they have what's called the all-payer system, and I'll come to that in a second. So we heard some of the examples of and I think how May described Uwe's recommendations to Taiwan about why to do single payer. I think the critical thing is really on the efficiency side to reduce the scope for cost shifting, right? So it's really hard if, like now, if, Medicare may make some change and so on, but the hospitals have other patients. They can easily shift, and the evidence is really clear that that's what they do, okay? So there's that. The other issues we heard, reducing administrative costs, the burden on providers in particular, and I think this has to be one of the selling points of what you're trying to do, is to actually make it easier for the providers to enable them to spend more time practicing medicine and less time filling out paper, right? The importance of getting to that unified database, which is critical, or interoperable database, to really use that to drive change. And then again, on the equity side, the fairness dimensions, that you get the same benefits, the same cost-sharing requirements for everyone. You may have special provisions for low income, and critically the same payment rates so that you don't get the kind of discrimination, the idea that, we don't serve Medicaid patients. So this is what Maryland did going back to the 1970s. And I can remember when I learned about this, about 5 or 6 years ago, I couldn't imagine that it could happen here. And I think the message here being, at least in the country, and I think this is kind of the message that it can happen here. So they got a waiver in the early 1970s, and it was just applying to hospital services, saying that all insurers, regardless of Medicare, Medicaid, private insurers, they all pay the same thing. And there's a single form, and there's an agency, the Maryland State Rate Setting Commission, which determines prices and so on. So it doesn't, the hospital has no incentive to discriminate against Medicaid patients, right? They're going to pay the same. There's always room for improvement. It happened to be just hospitals, but this is one slide that they like to show, that in the early 70s when they started, Maryland was a relatively high-cost state. And this was in pink here, the rate of hospital expenditure growth over this period as compared to the US. So much lower growth, right? Attributable to those things like reducing administrative costs, to setting the prices in a way that was able to do this and so on. And really, they grew the system much more slowly. And the estimates that the guy who I'm quoting here, Robert Murray, who was the executive director of the Rate Setting Commission, and somebody I think worth talking to here, because I can tell you about what has been done, but it's probably a better idea to talk about to people who've actually done things, right? So that would be useful. You know, and he said that if the rest of the country had done this, we would have spent about $2 trillion less. So, you know, if nothing else was changed, just because of that. So that's some reasons about why the single payer. It is important to remember that just having a single payer is not enough. And you saw when we were trying to start our session today that we have a lot of people in the room who know a lot of policy and have a lot of good ideas, but it wasn't until, what's your name? Isaac. So it wasn't until Isaac came that we could actually implement anything, right? So we needed to, you know, actually have people who know how to do things as well, and not just how to talk about them. So this is just really important, right? And you remember, obviously, the first months of the ACA when you had some real disasters in implementation. So easy thing for me to say, don't do that, right? Really get that together. And you know, we have examples in different parts of the world. You have many of these single payer systems. They don't work equally well. Some work better than others, right? So it's not only a structural issue. There's not a magic solution that if you get, you know, the boxes and arrows right, then everything's fine. Okay, you've got to really enable, put in place the means. And again, we heard, and I'm emphasizing the third time, May noted this as well. We heard yesterday that actually there was already steps taken by the previous administration in California to move towards setting up a single database, right, or an interoperable one, a statewide claims database. It may take a while, but you know, the sooner to start, the better, because it's really hard to do any of this other great stuff until that's there and you can use it. There's a lot of things needed to put this in place. Others, I know, having more, the other idea, just you know, lower the age of Medicare eligibility to kind of 0, right? And then you have that, so that would be another option, something that functions, that works. And then the other important point, I think, which we heard about, and I think certainly say, and you could imagine in Canada, but we also heard in Taiwan, that everybody having an insurance card is not enough. There's a whole lot of other things that get in the way of people being able to use services, reaching underserved areas. So it doesn't mean, even if you have an untargeted insurance benefit, you still need focused action to reach the hard-to-reach groups. And I think you obviously know that better than I do. So it's not enough to have a single payer, but not having one makes it really difficult. Okay? So the idea that you're going to get a lot of efficiency gain, you're going to get everyone in, it's possible to do in a multi-payer arrangement, but it's extremely costly and difficult, right? And we've been in this situation going back to Hungary again about 10 years ago, where they wanted to break up their fund because they heard about lots of other good multiple payer examples. And my reaction was, you know, you'd have to create their problems before you created their solutions, right? So first fix that. And it's just really hard to do. And we heard, I mean, some other things which I think are really important, that without a single payer, it's hard to actually, the incentives to invest in promotion, prevention are not really there because you don't capture the benefits in a way that could be lost to some other insurer. So you want to internalize that within the system. You need to have the power to influence the providers. We heard some of these shocking price differences of what Taiwan has been able to get, you know, and so on. So, I mean, these are really important issues. And so what we saw, despite all those different structures of the insurance market, is other countries and other high-income and increasingly middle-income countries are moving towards this more single payment system, okay? And it's simply not, and part of it is, you know, it's not just a technical decision. It's not okay to have these explicit differences in entitlements. Right? It's kind of become okay here. We're used to it. And the idea that everyone should have the same is what seems radical here, right? Which is just the opposite of, you know, what most other countries would want. So this idea that, you know, retaining this fragmented system with different benefits and so on, it's really hard to argue in favor of that. I mean, people will, but it's really hard to address the cost problem. And in a way, and this is, I think, part of the challenge, you want to maintain the incentives for innovation. You don't want to lose the good parts of your system. The idea is to put that within a framework so that it's actually innovating in good things, not innovating in how to avoid risk, right? And Riza gave that example. When you look at the concentration of health spending, right, that insurers they do. The evidence is pretty clear. They want to select that preferred risk. And so, we use this term strategic purchasing to talk about being much more effective with the money that you've got. And we want that, but what we don't want is what I would call strategic pooling, right? It's just, only selecting the preferred risks. So this is really the issue. And again, that importance of why it's easier with the single payer arrangement or single payment system, I would say. And again, you can have multiple insurers with a single payment system. One thing I've seen in countries in many different parts of the world, when they do a big coverage expansion, and I think this was also part of something that may explain something that happened with the ACA, because you remember after the first year, then suddenly there was a big premium increase, right? Now, there could be a lot of reasons for that, and I can't say that this was it, but it's consistent with what we've seen in countries, often like lower and middle income countries around the world, when they reduce barriers, which is that the policy worked. It worked because the aim of the policy was to address unmet need, okay? And so people came, which was great, except people came, and then suddenly you have to find the resources to manage it. So it's what I call, you'll get a utilization bump if this policy works, right? You'll get an increase, and the point is not to be surprised by it, just like no one should be surprised when there's DRG creep or other things like that. So it's more about kind of front-loading the resources a bit, being prepared early on to do it. And it may be that the administrative cost savings will be more than compensating for this, but the time frame of that might not be the same. Even within 1 year, you might get that sudden increase and having problems in the first 3 months, which politically is not a good thing. So being ready to kind of front load on that is important. So what's different about this country? We saw different slides from Reza and May putting the U.S. in comparison with other countries. This has now become my favorite way of showing it, and this trying to give my honors to Uwe as well for changing his wording a little bit. But in the spending, a lot of it is the prices behind the spending. What this is saying, according to our most recent database, which is for 2016, which is that the U.S. has about 4% of the world's population and accounts for 43% of global health expenditure. Yes. This is in current dollars, and basically the U.S. has about 4% of the world's population and accounts for 43% of global health expenditure.
Okay.
Yeah, so it's a lot, right? I mean, I guess, yes. Okay. Only 43, about 43. Okay, so a couple of things that we don't see elsewhere that is the case here. One is simply that there's there are differences. It's not that all these societies are uniform. I mean, there's a lot of discussion about, a bit more state or a bit more market in the system, but fundamentally, there's an agreement that this is something that the state has to provide. And even under Thatcher, who was introducing, a lot of people concerned she was going to overturn the NHS. She couldn't overturn the NHS. She could inject a bit more of private incentives into it and other things, but fundamentals were not affected. And then this last part, which is important, that in the rest of the world, the way that healthcare is financed doesn't put small businesses at risk, doesn't interfere with people's choices about this. And when I say in the rest of the world, I'm talking in other high-income countries that have universal systems. In low and middle-income countries that don't, we do see some of these things. That's something that happens. But basically, in the systems and countries that you're trying to align with, in a sense, you wouldn't have these problems. Okay. So government policy has to steer There has to be some limits on what's provided. I think the point is that, and this is really, it would not be acceptable elsewhere for the decision of who gets what to be left up to private actors. So the decisions on rationing, which I know is a dirty word here, right, in this country, are made by government and not markets. But at least when I was learning economics, we were taught that that's what markets do. They ration, right? So this is really something that needs to be clear. And then all of these countries have some private insurance, or almost all of them have some private insurance, but it's outside of the core benefit. It's either complementary, as in the case of France, or supplementary, like in the UK or so on, and it doesn't cover the things that are covered by the public benefit package. And there's no such thing as this, which a colleague put me onto, that there's no such health worker as a denial nurse, right? So, that would really be a political scandal anywhere. I guess this was from California, this case in particular, right? The last words I'll say are, in our policy dialogue with other countries, we're always trying to say we don't want to debate the instruments until we reach some agreement on the objectives. And the question is whether this is the objective that you want to have a system where everyone is able to access good quality services without fear of the financial consequences, whether it's for themselves, their families, their businesses, or their jobs. So it's really critical to win that battle and then see, how to navigate the game in terms of the best way to get there. So thanks very much. Honorary pin, that's just the pointer.
I'm sorry we're running late. We started late, but our next speakers will be on coming back to California. Jim Kahn's next.
Thank you. We've heard some wonderful talks on single payer in a couple of specific countries and then the rest of them. Thank you, Joe. And I think that the challenge in thinking about single payer for the United States is how do we translate that experience to what would happen in the United States if, or I guess I could say when we move forward to single payer. So that's what I'm going to talk about. We did a review of studies of the cost of single payer in the United States. What we did is first identify these studies, they're generally economic models, of the cost of single-payer proposals in the U.S. and for specific states. We extracted information about the single-payer plans and also how the analyses were conducted. We then also extracted the results, which included the cost increase due to higher utilization. So obviously, if you give uninsured people insurance, and these days it's important to note if you give underinsured people really good insurance, you're going to get a bump in utilization. That may be constrained by the number of doctors. That's a whole other discussion, but we assumed, and these studies all assume no constraints, just more people insured, they're going to get more services. But you get then savings due to a variety of factors. We've heard about administrative simplification, and I've done some work with colleagues that showed that we're spending about $1,400 per person per year in excess billing and insurance-related administrative costs. So that's the biggest single chunk of savings. You have drug price negotiations modeled on what the Veterans Administration does, which is roughly a 30% rate below what private insurers pay. And there are other elements to the savings as well. Put that all together, you get a net cost. We did this in percent of current spending. Of course, all the original studies were done with the health spending, the nominal health spending at the dollars in those years, but in order to allow comparison, we translated it to percent. So I have two results slides. This one here is organized from the economic model that showed the highest net cost. This is in the first year of operation. This slide does not look at increasing cost control, improved cost control over time, which, as we've heard, is very important. But this just looks at the first year. We have a couple of studies here, 3 studies which show a net increase in cost in the first year. That is the increase in utilization. exceeded the savings from administrative simplification and so on. And then the remaining studies, all of these, the red bars are the increase in utilization, the green bars are the total savings, and the blue line, is the net. And you can see, again, these are ordered specifically by the net savings. The net savings, and for most of these studies, are anywhere from from 0 up to about 15%, 17%, but the median is about an 8% net savings in the first year. Next slide. And I will say, this is the last slide. So Nina really read me the riot act. Yeah. So what we did here is we organized the studies in this particular slide by the year they were done. And the red bars continue to represent the increase in utilization. The bar next to it represents the savings, and they're color-coded. So for example, in this first study by the GAO way back when, there was an overall slight net savings because the savings from administrative simplification, which was the only savings that study looked at, was slightly more than the increase in utilization. Looking over here on the far right, this is the most recent study. Robert Poland and colleagues looked at the new Sanders Medicare for All bill, and the increase in utilization, again, always as percents, is this red bar, and that is substantially outweighed by the savings anticipated from here, the administrative savings. Then the green is lower prices on drugs and durable medical equipment. The very faint green here is reductions in efficiency and fraud, and the yellow is Medicare payment rate. Not all studies, in fact, the minority of studies assumed a different payment rate. You can see wherever there's a yellow bar. This one has, this particular study, which is recent and very much has been in the news, is showing these 4 types of savings. And I wanted to mention that the efficiency and fraud reduction here is pretty small. I had long discussions with that team, and we looked at ACO evidence, and right now we can't do a whole lot to accomplish that, but there is some hope that with single payer, with better data systems, really optimal data systems, we can do better over time. Anyway, I don't want to take more time. I know we're running late. I'm happy to talk with people about this. You can see, you saw the kind of the count in the last slide, and here, if you study it, you can look at the breakdown of the different kinds of savings. The gray bars here are studies that didn't break it down in any detail. So thank you. I think, did I do it, Nina? Did I keep on time?
Thank you so much.
All right.
And now, reference to some top economists in the room, Richard Schaeffer.
Well, okay, I want to start by saying how honored I am to be here at the Rick Brown Symposium. We want to take credit also for Rick's career since he got his doctorate degree at Berkeley. And so it's an inexhaustible resource. Whoever wants to take credit for it, that's fine. So my job is to bring us a little bit closer to where we are now and to talk about California. This is the work I've been doing with my colleague and good friend Steve Shortell. Am I supposed to be able to press something here? Okay, back.
Probably just use the machine.
All right, May, we need, oh, there it is.
The laser.
All sorts of things to press, but I didn't get the right one. Okay. So let's back up a slide a little bit. So I want to tell you that we titled this the 7% solution because I'm a Sherlock Holmes fan. And so that is essentially how far we have to go in California to move on universal coverage. And we're close enough that I believe that this, California has the chance to be literally the first state to make it over the line. The approach here is a public-private approach. So whenever you do something like that, There are going to be people and populations that fall between the cracks. There isn't much we can do about that, but I do believe that we have the momentum to move forward. So let me show you why I think that's the case and how I think the math can add up. So first, we use the data that is basically from the Cal Sims model, which is, in fact, as Professor Kaminsky said, that a great collaboration between Berkeley Labor Center and the UCLA School of Public Health. They are the gold standard, essentially, for the numbers uninsured. I should tell you, I've been trying to keep up with it, and it changes almost every day. So tomorrow you can wake up, or Monday, and you'll see another estimate of the exact numbers. So just take these as ballpark figures, the most recent ones that we get our hands on. So basically, there's 4.2, about 4 million. If you put in, reinstate the individual mandate, that goes down by about 0.3 million. So the net is about 3.7 million. That's our current estimate. And as I mentioned, that's going to change on Monday morning. So next, trying to cost this out is also a matter of policy judgment. There is no exact rigorous method of coming up with a cost. Different people will do this different ways and come out with somewhat different numbers. But I can tell you, having looked at the literature and people doing this independently, and Steve and I did it independently, the numbers are not that far off. So in a sense, they'll be different, but they are essentially in the same range. So the big number is, of course, this one here. There it goes, okay. If you want to cover the undocumented and put them in Medi-Cal, full scope coverage, that's $2.7 billion. And then we have those about 750,000 eligible for Medi-Cal. That's $2 billion. Now this group is something that the state would already have to pay for, and so they're liable for it. So this is going to happen anyhow. And then you get the 0.35 million in the ACA who don't buy coverage because they basically can't afford the premiums. So we took a halfway measure and said, suppose we paid for half their premiums. Would that be enough to have enough of these people go into the market? That's a policy judgment. You could decide you want to pay for it all or 3/4. We just took halfway. And that basically would cost $1.1 billion. We don't include these because they're already eligible in the ACA, they're high income. And this is a group of people who are eligible for health care coverage but don't take it. They're often low-wage earners who say, well, even though I have to pay only $50 a month for health care coverage, I need that to feed my family, and I'd rather have that in wages. So basically, we've given them an opportunity. We've made it very, very inexpensive, but they still don't take it. And that's one of the problems with health care. People have to trade off health care for wages and feeding their family. So at the end of the day, it's $5.8 billion. But if you think of it differently, if you think about the incremental or marginal money that hasn't already been committed, the number is $2 billion less because the state is already obliged to pay for the group in the middle. Okay, next. So this is just a summary slide to kind of put that all together. You can see where the blues come from, and since we're out of time, I'll move through this one quickly. And so, how do you pay for this? So we looked at two main sources of funding, and one is this is a provider tax. This has been used in over a dozen states quite successfully. The first state was in Minnesota. It generally is reasonably popular among the providers. They don't like paying taxes, they don't want to pay it, but for the reason it's somewhat popular is it injects a lot of new money into the system. So they're getting a lot of money, and then some of it is taxed back in order to help finance this. So we looked at three groups, basically institutional providers, physician groups. We defined the group 25 or more pharmaceutical sales, and health insurance revenues. And if you do the math and work out basically a 1% tax, you end up with $2.5 billion. Now, there are other groups that could be included in this. When I put this out, and I got some nice response from the public, one wonderful person suggested, what about the medical device industry? Why did we leave those out? Well, I forgot. So let's put them back in. So that would be okay with me. So this is a living, breathing kind of document. I didn't mean to leave them out. I just overlooked it. So anyhow, this is kind of a general plan and a notion about how to get this done. These are not meant to be exact, precise estimates. The next thing we looked at, next slide, was something that, of course, that happened in San Francisco, the San Francisco Health Plan. This is essentially a pay or play, and you know, if you cover your workers, well, that's good. If you don't, and you have various ways of covering your workers. I could spend 45 minutes. I'd have to learn the details of that, but there's a long list of 10 or 12 different ways you could cover them. But if you don't, you have to pay into a fund, and we simply took the San Francisco numbers here, and that's the number of firms, 20 or more. That's the employee. That's what they paid in for the most recent year, and then we just scaled it up. And basically, if it became a statewide program, you could generate in the ballpark again of $3.3 billion. So next one. So this shows you that these two together, most of it coming 43% here, and the remainder from scaling up this to a statewide program. Next slide. So we've put out a lot of documents. We're trying to add some value to the amazing work going on already at UCLA and other places. And so if you want to see some of our work, you can click on Petrus here. We had a letter in the New York Times on Monday promoting this plan. And if you click on it, you get to see it. That's got a lot of exposure. 4 million people read the New York Times every day, and I don't think I published 300 journal articles. I don't think that 500 people have read them in 30 years. But in any event, you got a lot of leverage in the New York Times, and then we have what we call a California Dreamin'. So all of these are click-ons, and we're continuing to work on that. Let me end by saying we're going to do 2 more things soon. Steve Shortell is going to lead a paper on how to move California to an integrated delivery system. Because in order to do this, you basically have to control cost. You have to have a sustainable system. And then the paper coming out afterwards, I'll be reviewing all the cost control mechanisms that have been tried in every state, including Maryland and Massachusetts, but there are others as well, and lay out some options for the state of California. So thank you very much. And
Thank you, Richard. There is still a very important part of this program, and so I invite Mark Peterson. This is the reaction from our panelists from California.
I don't need it.
And it looks like a lot of you are not leaving, which means you're very interested. Thank you for staying.
Okay, thank you, Inez, and thank you, everybody. It's wonderful to be here. It's always an honor to be involved with anything that has association with Rick Brown. And in some ways, this panel coming up is going to be a lot about the way Rick went about the world. We've just had wonderful presentations about the details of single payer and versions of single payer around the world. In a way, a couple of major questions that come out of that would be, can California do something like Taiwan, which is actually go out and visit the world, see what's happening, work through data analysis and research, and design policy in an instrumental and thoughtful way? A question that's not usually answered in the affirmative of the United States, but maybe California can set the bar for that. The other question is, we know from Canada that Canada is a federal system like ours. These kinds of issues really dominate at the state level. But Canada, unlike the United States, really had an engine coming out of the provincial level. Saskatchewan being really stepping up to the plate. And so the question is, can California be the Saskatchewan of the United States? But these are pretty high-level high-level issues, and we know from Joe's presentation that even though this is happening around the world, these are difficult to deal with. They're extreme challenges. He talked about some. Rick Cronick mentioned the series of challenges that we have in terms of pooling federal money at the state level, in terms of stakeholder resistance, in terms of public resistance in some of these regards. And so the next question really is, how do we get concrete about these things? How do we think about what can actually happen today? And this is part of Rick Brown's vision. That twinkle in the eye was very often a sense of grand aspiration. Rick wanted a single-payer system, but Rick worked very hard at every single margin that was given by the political system to get to the next step. And one of the things that he was very sweet about is when the Affordable Care Act finally passed, he invited me to co-host with him and Marianne a party to celebrate that enactment. Well, that ACA is not what we were envisioning, but it was certainly a step forward, and Rick was going to work hard at it and going to celebrate it. So we're here today with a panel of people who are dealing with these issues on the ground, concretely, all the time. And unfortunately, even under the plan for the conference, we're going to give them very little time apiece, just really a few minutes to take shots at these kinds of questions. We're going to go in the order of Anthony White from Health Access, Laurel Lucia from the UC Labor Center, Sarah DeGuia from the California Pan-Ethnic Health Network, and Arthur Chen, California Physicians Alliance and Asian Health Services. And unfortunately, Hector Rodriguez was going to speak with... Rick is going to join the panel. The man who does everything. So Rick Cronick as well, who has very long experience having worked on the Clinton Healthcare Plan, the ACA, and was also director of the Agency for Healthcare Quality and Research and Quality. So please, why don't you begin?
So really pleased to be here. My name is Anthony Wright. I'm the Executive Director of Health Access California. We're the statewide healthcare consumer advocacy coalition working for 30 years on the goal of quality, affordable healthcare for all. I will use even just a few seconds of my time as a personal prerogative to also honor Rick Brown, who was actually the chair of our board for years before I was at the organization, but was always a friend and a ally and a champion for this cause of getting to universal coverage, and so we continue to miss him, although we're so pleased to have such a great academic community here in California. Many of the folks that you see today, we're really glad to work with them on this effort to get the best evidence-based program working to get to these goals. I think I was struck in hearing the conversations about this tension between sort of these big, broad goals of what other countries do and how we could potentially get to the vision of a universal and even single-payer healthcare system, something that my organization has supported and championed for 30 years, with the sort of the on-the-ground realities of our existing system and the particular issues of the moment, the battles of the moment. We've always worked at for universal healthcare, but then dealing with the issues here at the ground at the state legislature. And I think we've identified that, as Rick said in those many hours of the testimony last year, that to get to that goal in one step in California does mean cementing a couple of barriers, whether it is not just industry opposition, but the issue of people not wanting to lose the coverage that they have now, even if the promise is for something better, or the procedural barriers of constitutional areas, and in particular this issue of federal approval, especially now when we have a federal government that seems to be hostile to healthcare in general and to California in specific. So we've been very active about what can we do in the next year, in the next 2 years, that's aspirational but achievable now in terms of expanding coverage. And I think we started to talk about expanding Medi-Cal to all, including the undocumented. I'd actually be curious about how some of these other countries deal with issues of immigration, which I think would be interesting to tease out, how to deal with greater affordability in the existing covered California system. But I also want to caution two other things. One is that I don't see this as an either or. I think that these are complementary strategies. That at the end of the day, what I hope that we're doing and what I've been doing in the 18 years that I've been at this organization is how are we building the infrastructure for, it's not just building on the existing system, how are we building the infrastructure for the next system? What can we do in terms of setting up financing systems, setting up public infrastructure in terms of broader purchasing pools, greater public coverage? I was fascinated by the chart about the co-payments and putting limits on cost sharing and dealing with those types of issues, putting in place that infrastructure so that when we can take that leap because of a different federal government and also an ongoing change in the mindset of our public, that we're ready to do so. And that is my final point, is that I do think that the one thing that we should give ACA credit, even though there are many things that we wish it had or it didn't have in it, the ACA did sort of, I think, call the question about, do we care for one another? Do we care for one another both literally and figuratively? And I think it's called the question, and I think that as grueling as the last 10 years of debate have been about this issue, I think we're finally getting to have some standard on that issue, and I think that's the most important platform that we can take about what we can do both in America but also in California in the next few years. Thank you.
Good afternoon. My name is Laura Lucia, and I'm the director of the healthcare program at the UC Berkeley Labor Center. Thanks to Ninez and the center for putting this event together, and to all of the experts for the great presentations. As Anthony described, and as Professor Scheffler described in his presentation, there is a lot we can do in the short term to get closer to universal coverage, and that's been a major focus of our research with our partners at the UCLA Center. A lot of our research has focused on the undocumented because they make up the biggest group of uninsured in this state, and we estimate that expanding Medi-Cal to undocumented adults could close a quarter of the coverage gap we have. We've done a lot of research on improving affordability in covered California because that's the next biggest reason for uninsurance in the state, and there's a lot that the state can do both for those who are already eligible for subsidies but can't afford it, and for those who earn too much. And then lastly, as Professor Kaminsky referred to in the beginning of the day, having a state mandate could reduce the number of uninsured in the state by up to 600,000 over time. And so these are all really important steps to take, and they're the focus of my research. But even if we achieve these steps towards universal coverage, the cost of healthcare is just way too high in this country, and even in the state, it's higher than average. And this is, and all of the presentations today, included that point. And this is a big problem for workers. They're not only struggling to afford premiums and get insured, but the cost can be a barrier to care, and it's also a big driver of wage stagnation. And it's a problem for employers too. And as Professor Chang said, it's still the prices. And so it gives me a lot of hope that there are all of these different ways that different countries have approached designing their healthcare system, and that all of the ones we looked at today, at lower cost. And so there's a big question about which model is best for California, and how do we get from here to there. And I think the Council on Healthcare Delivery Systems that the legislature has set up has raised the right questions that need to be addressed. And one of the questions that's raised is about how do we control costs. And I think even as we consider the longer term, more fundamental reforms, we need to be asking that question in the short term, because just like there are steps the state can take to get to universal coverage in the short term, there are steps the state can take to try to control costs, although it is more difficult in a multi-payer system. And so one example of that is a bill that was introduced this week on out-of-network emergency room costs, which not only protects consumers from surprise bills, but would also cap how much hospitals could charge insurers. And that doesn't require federal approval, and is one example. And so as we have our later discussion, I'd be really interested to hear from the experts on ideas on, in our current system, what can we do to control costs better?
Good afternoon. Thanks to everyone for sticking around for this great conversation. Thank you, Ninez and the Center, for inviting us to participate. And like Anthony and others here, CPEN has had a great partnership and worked really closely with Dr. Brown when he was with us. And thank you to all the experts for traveling so far and sharing your knowledge and information with us as well. I'm with the California Pan-Ethnic Health Network, CPEN. We're a 25-year-old multicultural health policy organization, and our focus is on improving health for communities of color in California, and we've been very supportive of single payer and also universal coverage, given that the majority of those who have been locked out of healthcare systems have been communities of color. And so the efforts that have been made, through the Affordable Care Act, for example, and extending coverage have been tremendous and have had tremendous impacts on communities of color in California. And our work on universal coverage dates back decades. Basically, we've developed a set of multicultural health principles, and of the first one, healthcare as a human right, is that first principle, and I think it's shared across a system of single-payer universal coverage. And we've been actively involved in Care for All and Health for All here. So I want to kind of raise 5 or 6 considerations in the brief time that I have. One is just to note that California is very diverse, and if we look at the demographics, we are a majority communities of color state. Over 60% of the population is of communities of color. About 38 to 40% are Latino. African Americans and Asian Pacific Islanders make up about 20% of the population. If we look at the 14 million lives that are covered through Medi-Cal, 80% are communities of color, 30% speak Spanish, and even within covered California, about 66% of those are also from communities of color. So the considerations that we need to think about in California as we advance universal coverage is, how do we meet the diverse needs of these communities of color, knowing too that we're talking about communities who have been historically divested in or who have not, had the same kinds of resources that other communities have had as well. And so any system, and I think Joseph mentioned this too, is that just because we expand access doesn't mean we're going to take care of all of those problems. And so as we look to build a system, we need to ensure that equity is really central to that as we go forward. And so a couple of the considerations that we have is, how are the services that we're providing really meeting the language and cultural needs of our diverse communities? And looking at the community health models, for example, that have really taken an integrative approach and that are really based in community and often serve the communities that we're talking about that are the most underserved. The second is really looking at how are we thinking about quality improvement. So I think, again, we talked about, access is one point, but access doesn't mean that everyone's going to get the care that they need. And I think both looking at the prices and how we're using cost containment measures regarding quality, but also really having an impact on reducing racial and ethnic disparities, because even just with having universal coverage, those disparities may not go away unless we really understand why they're there and ensure that we're reducing those disparities. We talked a little bit, I think Dr. Scheffler talked a little bit about, looking at integrated models and having more of a comprehensive system. So how do we make sure that we are, really baking in oral health and mental health? We cannot, separate those kinds of needs and incorporating those as a part of the overall healthcare system. Data is really important, and I think data not just from a perspective of we need to have really good disaggregated data that's also looking at those disparities, and also really that's helpful for consumers. Our consumer assessment right now in terms of consumer surveys isn't very good, and so how do we think about bringing consumers and having consumers really be engaged and take part in holding people accountable for the quality of care that they're getting and also the kinds of utilization that they're using. And then the last 2 points is just around also consumer rights and knowledge. Clearly it's an important aspect. We need to have good protections in place for consumers that are cost protections, but also so that they know and understand how to utilize the healthcare system that they have. And last, for us, equity really is about reducing disparities, and so it's important to have that ability to pay and ability to access care, but also, again, really looking at how are we reducing racial and ethnic disparities or other kinds of disparities that our communities are facing. Thank you very much.
Good morning. My name is Arthur Chen. I'm a practicing family physician. I'm on the board of CAPA, the California Physicians Alliance, and I too have a special relationship and fond memories of Rick Brown and appreciate everything he did. He was actually one of our earliest CAPA members when we started almost 30 years ago, and participated and came and gave us presentations and inspired us along the way. CAPA is a mission-driven organization, value-based. We believe strongly that healthcare is a basic human right. Therefore, we work towards educating and advocating for health systems and healthcare reform that achieves truly a guaranteed, universal, accessible, affordable, high-quality, and comprehensive care system for all. And so from that perspective, we have a three-pronged approach, which is number one is increase access now. We appreciate the gains that ACA has made and been able to expand coverage, and we strongly believe that we need to preserve it. A second approach is that we believe in getting improvements and seeking improvements in the care and healthcare reform that are achievable now. So we are in sync with many partners that are here that are working hard towards healthcare reforms and that can deliver, through different types of legislative approaches and strategic steps towards change. And finally, our third prong is that we are creating a roadmap towards single payer, towards a publicly financed and privately, as people have mentioned, privately delivered healthcare system. We believe strongly that the competitive side of that is really positive and innovative, and we're committed to that. So as far as my reaction to today, I want to appreciate the speakers, and I was very moved by a lot of the work that they're doing. We believe that we need a master plan in California, a comprehensive plan that doesn't focus only on the financing, but a number of people have brought that up. Diversity is an issue in California. I won't repeat a lot of the statistics, but just to say there are tools on the how to actually address diverse populations from a cultural and linguistic access standpoint, from a rural-urban standpoint, any way you cut it, LGBT-wise, sexual orientation. I want to lift up the class standards, which are the cultural linguistic appropriate standards that have been developed back in 2001 and have been updated in 2013 and are a template for how to run an organization or run an entity or run a system to pay attention to the diversity of the participants involved and should be adopted. The second thing I'd like to say is that we need to look at workforce issues. One of the questions I had for Dr. Jung was with the incredible utilization in the Taiwan system of over 10 visits per year, and average length could stay over 10 days in hospitals, and being able to provide all those services. What attention did the system as a whole pay to workforce development and ensuring that there is the proper trained people? And in our current context of very complex patients, particularly where I am practicing in the safety net in a federally qualified health center, how we build teams and how we build teams of multidisciplinary approaches where we have an integration of behavioral health and physical health, oh my gosh, and all the social type of issues that people are facing in their root causes. That is how we would address the diversity issue. That is how we would curtail and strategize on how to prevent some of the health disparities as part of advancing health equity. How do we use technology? Because technology is here to stay. As far as the device industry, that was a very interesting comment about how it might get out of control. But seriously, there are decision support systems that actually will help us improve the quality of care. And I use them as a practicing physician. I carry my cell phone with me into the exam room now, and I will go over, any type of intervention that I'm going to suggest or recommend. I will go over side effects of medications with the patient so that real time, I don't have to worry about going back and studying that and then coming back with a recommendation. I can actually do that in the course of providing this and get updates on some of the latest therapies as well. So technology is a friend. If we use it, it extends ourselves in telehealth. We utilize this in dermatology right now where we can't access clinical dermatologists, and we take pictures and can send them over an encrypted pathway, whatever it is in cyberspace, and get a consult from a dermatologist to help us guide our patient care. And so it's very significant, and we should pay attention to it. And then finally, All of that has focused on the downstream failures of our healthcare system. And we know that in healthcare, getting access to healthcare is going to help us address maybe 10 to 15% of preventable, avoidable deaths. And so what about the others? Lifestyle changes, the environment, genetics, and so on. We need to pay attention to upstream, and that means the social determinants of health and the things that influence our behaviors in our communities. Is that they took a comprehensive approach. There was a reason why it was 1,100 or 1,200 pages, whatever it was. After you finish reading, you can't remember how long it is. It's just that it's really long. But the main point there is that it was comprehensive. It took the issue of prevention and invested in it and had a $15 or $16 billion allocation towards prevention and public health. These are the kinds of things that we need to look at in California reform as we're going, so that it isn't siloed into just what focuses on downstream delivery. And then last of all, as far as the frontline providers, I'm a great believer in Toyota and the remarkable ascent they had in the car industry because they paid attention to people on the assembly line. They worked with people on the assembly line to problem solve. The very practitioners that are out in the field that are sitting here, many of you that are sitting here today, are critical voices and problem solvers and are solving a lot of these problems the best they can, the best that we can, as we speak. And so maintaining that communication line for the sake of improving quality, for the sake of making sure that we preserve the provider-patient relationship. And I say provider because it's more than the physician-patient relationship. We have nurse practitioners, we have mid-level practitioners, physicians, assistants, nurses, and social workers, and many people on the team that interact with the patient, that we need to preserve that. And then there needs to be fairness. Fairness because we know from the industry, driven by cherry picking, that a lot of people get left out, and we do not address the critical needs of our most complex and challenging patients. And most of us in the safety net and in other settings are willing to take that on, but at the same time, there must be fairness in the way that that reimbursement and so on is driven. The last thing I'd say is public will. There's a three-legged stool, there that Uwe Weinhardt presented. In public health, we have a three-legged stool around data, around policy, and around public will. And without the public will, we can't accomplish a lot. We need to pay attention to community engagement. So it's not just us policy people sitting here talking about things, but we also, when my role of a philanthropy hat, we had the luxury of convening experts and convening in communities and hearing stories that come from great leadership that arises from our communities, both from veterans that are in the community, but also from youth in the community. And we need to pay attention to that, and that would also help inform a lot of our approaches. So Canada went from Saskatchewan to the federal government to the entire country covered in 9 years, I think, and Taiwan went through a legislative process, and it's looked like 18 months, and implementation in 9 months, so let's get going. Thank you.
On the let's get going, I'm sure everyone wants to get going, and I will be very quick. Anthony and Laurel and others have energy around short-term change, and it's just incredibly exciting to have a governor interested and committed to change, supermajorities in both houses, tremendous opportunities. Art talked about the need for community engagement, involvement. I think that, the longer-term question of, will we agree on the principle that Joe put up, or something like that principle, that we should all get care by virtue of being humans and not by virtue of our age or our disability or our employment status or our income. That conversation needs to happen. We have a presidential election coming up. Presidential elections don't tend to be great opportunities for meaningful conversation in the hyper-partisan universe that we're in, but on the other hand, it's what we've got. And I have, some hopes for that conversation. We have the Council on Delivery System Reform that Laurel mentioned, that the legislature that was created last year, yet to be formed. Whether that council can foment conversation, not so clear. But the one thing that does seem clear is that if we're going to get from this crazy fragmented system that we've got to a system of unified public financing, that the public needs to be involved in that conversation. And then my last comment is I do fear that the conversation will be focused more on the question of should we have health insurers or not, as opposed to should we all be in the same pool to begin with or not, which I think is far more important. And even actually on May, your use of Uwe's wonderful pipe diagram, I think the U.S. story is that we have all the different risk pools to begin with, and then from there to providers with different risk pools. And if we could get to a situation where we were all in one box to begin with, whether then the pipes to providers were somewhat separate or not, as we have in the Medicare program with Medicare Advantage, is really a kind of second order question, I think. But whether we can have that conversation intelligently is clearly hard, because it's hard even with us experts. Probably some of you are shaking your head like, what the hell is he talking about? So, thank you.
Thank you very much.
Thank you very much for this robust conversation as promised. I'm sorry it took longer, but thank you for your attention. We will have the slides and some of the presentation at our website at UCLA Center for Health Policy Research. Our URL address is very easy, healthpolicy.ucla.edu. And I wanted to thank Senator Pan for hosting, and also the sensational committee that helped form this exceptional program. Thank you.